This is Sherona Bau, and this is her MASLD Community Network meeting tonight. We encourage networking throughout the presentation, but if you do have specific questions, you can drop them in the chat, or we will have time at the end to ask questions to Sherona as well. But for now, I'll pass it on over.
Thank you so much.
You
Thank
could
you,
just click
Christine.
the screen and it should go back.
Thank you. Welcome everybody joining this virtual meeting. I saw three people that I know really well. Thank you, Dr. Saab, Valerie, and Blanca. I know we have probably Amy coming and then maybe another 2 or 3 people coming in. So this meeting is only 30 minutes. I guarantee I will not go beyond that. And this meeting is particularly talk about, how come I cannot move forward? Christine?
Yeah, just can you click on the screen? Yeah, use your
Click on the,
mouse.
oh, okay.
Okay.
And then,
Okay, you're good. That's you.
oh, okay, good. Okay, so I take charge. Okay, so this topic today is non-invasive testing. So why do we have to talk about this non-invasive testing? That's really very important. I want to kind of give everybody a brief introduction about why we have this topic, because now we know that 25 to 30% of our general population in the United States actually diagnosed MASLD. So back then we only use like gold standard liver biopsy to test if the patient that they have MASLD or they have MASH, and then to see how much risk they develop fibrosis or cirrhosis down the road. But are we going to do a liver biopsy on 30% of our population? Definitely no. So that's why we will have the non-invasive testing to kind of give us similar idea to check when the patient will develop advanced fibrosis, or if they have cirrhosis, or if they actually find that they only have fat in the liver, have no fibrosis. So that's why we have this topic, non-invasive testing. And very important, I want to let you know this, you can scan this QR code because this educational program is sponsored by Madrigal. So you can actually scan this QR code to review the Madrigal MASH disease state education and the Rezdiffra promotional program. So let's start with a case, because it's very important that we use the case and talk about how to use NIT to risk stratify Mr. Albert. So he is 65 years old, Hispanic man, and his BMI is 29, so he's a little overweight. So one day he come into our clinic with abnormal liver tests, and also he bring in abdominal ultrasound, which show hepatic steatosis. So, and then when we ask if he drink alcohol, he doesn't really drink alcohol. He has all the metabolic disease, type 2 diabetes, hyperlipidemia, high blood pressure. And when we do a physical exam, he does not have any stigmata of advanced liver disease, but he actually has a BMI 29. So when you look at the lab, everything is pretty good. The triglyceride is not so high, 89. He has good HDL over 40. He has 41. And the A1C, you can see he has type 2 diabetes, 7.2. His ALT also elevated for years. He doesn't have any other chronic liver disease, which we already rule out. So for this patient, Mr. Albert, so we know because he has abdominal ultrasound show hepatic steatosis. He doesn't really drink alcohol, so he does not have met ALD. And then he also has high BMI and metabolic risk factor. So we know he has a diagnosis, MASLD, metabolic dysfunction-associated steatotic liver disease. So let's go straight to our non-invasive assessment for the liver disease. So you can see this slide is a little more complex. There's 18 different ways to assess liver fat and liver stiffness. And I'm not going to talk in detail every single one, but I still want to more focus on this slides because I think it's very important. We use so many different ways to assess the liver stiffness and also liver fat So on the left side, you can see is imaging biomarker. They use MR elastography, MR-IPDFF, and also shear wave elastography is SWE. And also we use FibroScan, aka FibroScan VCTE. And we can actually use those imaging biomarker to kind of know how much fat the patient has and also how much liver stiffness the patient has. So moving into the middle is combined rules. Combined rules meaning is combination of at least two things. So the first one is fast. It is FibroScan with the AST. This is actually giving you the idea if the patient's score is less than 0.35, it means we rule out advanced liver disease. If the patient's score is greater than 0.67, we kind of rule in the patient has advanced liver fibrosis. So after the fast, the right next to it, right underneath is ME-FIB, is MR elastography with FIB-4. So those two combination is an index. So you can see either the patient is positive or negative. So the cutoff for the MRE is less than 3.3 kilopascal, and the FIB-4 is less than 1.6. If those two tests show negative result, meaning the patient has very low risk to develop significant fibrosis. And then the last thing is MAST, the MAST is MR elastography or MRI-PDFF with the AST. So this is also a non-invasive test to predict the risk for liver disease progression. So moving to the right side, you can see that is some formula like FIB-4, NAVA fibrosis score. So those are actually blood work in addition calculated with patient's age and also the metabolic risk factor. So FIB-4, you can see is 4. So we know there's a 4 component. It is the patient's age, also is the AST, ALT, and the platelet count. But the downside for the FIB-4 is because the patient's age is 25, because since we only have 4 components, and then age actually is one of the components. So 25% of the component you go to patient's age. If the patient is a little older, elderly patient, so they are older than 65 years old, you might actually give them a positive result, false positive result for high liver damage, which they might not have. And the next one is NAFLD fibrosis score. This score is much more complex because it has 7 different components, including the patient's age, the BMI, the status of diabetes, and also AST, ALT, platelet count, and albumin. So this score, if it is less than 1.4, the patient kind of unlikely to have advanced fibrosis. If the patient score is more than 0.67. So you think the patient might have advanced fibrosis. So the next one is APRIP. I think everyone probably know is the AST platelet ratio index. So if the patient has less than 0.5, meaning it's unlikely to have fibrosis. And if more than 1.5, the patient has advanced fibrosis. So the right lower corner, it is all blood work. The first one is ProC3. I don't think we ever use that ProC3. I think correct me because Dr. Saab, you probably know this is not FDA approved, and I don't think we have ever ordered that. ProC3 is actually a blood work to test the fragment of the collagen type 3, and which is released during the active liver fibrogenesis. But we never really use it. We more use the ELF test, enhanced liver fibrosis. This test is a very simple blood work, and we are so lucky we can order. So far, I haven't had any patient complaint that is not approved by insurance so far. The turnaround time is about 3 days, and it basically gives you the idea how much risk the patient will develop cirrhosis or advanced fibrosis. I will talk a little bit more about the F test in the following few slides. The FibroSpec and Fibrometer and FibroScan, those are also blood work. And I remember I order FibroSpec a lot when we treat hepatitis C patient. So basically it's a blood work to give you an idea how much fibrosis the patient has, but it's not really, really accurate to give you an exact number. It's just the range of the fibrosis. So moving, the first NIT that I'm going to talk about is FIB-4. Since this blood work, it is free, mainly if the patient have basic simple labs such as platelet count or AST and ALT, and we can calculate the number and give the patient roughly idea if they have any risk to develop advanced fibrosis. But I did mention because 20% of the component is go to the patient age. If the patient is very old, maybe 65 years old or younger than 35, might give false positive result. So it is important that I think as a provider, you need to take into consideration if you order it and you know how to interpret it or when to order next level of NIT if the patient fall in the indeterminate risk range. So the next one is ELF test. So we order this ELF test very frequently, almost every day. So the problem for this ELF test is you can see the cutoff on the left side. If the number is greater than 9 or above, it has 60% of specificity and 85% of sensitivities. What it means is if the patient has ELF test, it can show good sensitivity for detecting advanced fibrosis, but it might have a limited specificity, particularly in the patient that they have low preference settings. So if the patient, you think they have low risk factor to develop advanced fibrosis down the road, but they have higher number that you don't probably think that the patient might have advanced fibrosis. So it has a high negative predictive value, but also it might you might not determine if the patient that they have high level of fibrosis if they have low risk of risk factor to develop advanced fibrosis down the road. So move on to our imaging. Imaging here, it did show us 4 different imaging. TE is transient elastography. We order every day. Luckily, we have the machine in our clinic. And then the next one is MR Elastography. I want to spend a little more time on the PSWE and 2D SWE. I do believe UCLA have the shear wave elastography. So PSWE is a single point shear wave elastography. So basically, it just measures one single point. We call ROI is region of interest. So it only measures about 1 centimeter by 0.5 centimeter of the liver tissue. And then a 2-dimensional shear wave elastography, obviously, is much more wide level of liver area. So it covers multiple ROI is about 2 by 2 centimeter, and it will give you more dimensional of the liver tissue and give you much more accurate of the liver fibrosis for the patient. So VCTE is, I just want to let you know, VCTE is really, really simple. It's about 10 to 15%, but that only give you 2 number, and I will pay more attention to the liver stiffness because liver stiffness is mainly to tell you how much fibrosis the patient has. And then the CAP score is basically the steatosis level, and it can tell you how much fat the patient has. But the liver stiffness, we measure by kilopascal, and if it is greater than 8, we might need to refer the patient to see a hepatologist because the patient might likely have some sort of fibrosis. So, but when we do VCTE, there's a few things we need to consider because we need to consider if the patient, if the operator actually is experienced. So by reading the VCTE, you can actually see if this is a valid FibroScan, if the patient has at least 10 valid measurements, and also the interquartile range per the median liver stiffness measurement ratio need to be less than 30%. That's important before we review the VCTE, because if the VCTE is not a good test or if it is not good quality, we might actually give a wrong result for the patient. So there's some limitation for VCTE, particularly when the patient, if they have high liver test. So usually when we see the patient, they come in with MASLD. The liver test shouldn't be that significant elevated. If it is more than 100 or maybe 200, you really think the patient has some other liver disease or maybe some kind of active inflammation. that I will probably hold off not to order VCTE, because that's important that if the patients, let's say if they come in with alcohol related hepatitis, the liver test is really high, and if you think the patient might have autoimmune hepatitis, because I know small percentage of the patient that they have MASLD, they also will have positive ANA autoimmune hepatitis, might be overlapped. So if they have a high liver test, I might probably hold off to order the VCTE, might kind of need to use another different kind of NIT to determine what is the diagnosis, because FibroScan cannot give you the diagnosis. For example, if the patient come in, the liver test show cholestatic pattern, and then the VCT will not give you good information. If the patient has any bile duct obstruction or any PBC, it will not give you that information. So I will not order VCTE. And this test also need to be fasting at least 3 to 4 hours. And I did mention alcohol use. If the patient really have excessive alcohol use, we might actually hold off to order the FibroScan. And very important, if the patient is so overweight, and I know although we have an extra large probe, when we perform the VCTE, and the machine will actually tell you when to change to extra large probe. But if the patient's BMI is over 35, that might not be accurate. So I will probably hold off and consider changing to order MR Elastography instead of VCTE. And if the patient has ascites, definitely you should not order VCTE because it won't be accurate. And if the patient has liver mass, and also important because FibroScan will not tell you what kind of liver mass the patient has, versus this slide, I'm going to talk about MR elastography. If the patient that they have liver lesion show on the liver ultrasound, that is important that we order MR elastography, because MR elastography is MRI. So we can order MR elastography with contrast. It is really important that MRE can give us tons of information, not just VCTE give you two information, the fat and also fibrosis. MR elastography will give you at least 4 information if you order with contrast. It will tell you what kind of liver lesion the patient has, or also will tell you if the patient has high iron overload, or if the patient has high level of fibrosis and the fat deposition. It's very important that we know at what situation we need to order what kind of NIT. But there's some consideration, because if the patient that they have implant, MR elastography may not be a good test to order. And if the patient that they have claustrophobia also, because this test is 45 to an hour test, so the patient might probably need some medication to kind of relax them. One thing is insurance might not approve, and I do have patient last week, and I have 2 patients that I ordered MR elastography, and it came back. We need to order abdominal ultrasound first, and then they will approve MRE. So that's why insurance is a big problem, that we might not be able to just order MR elastography. And also, it has long waiting lists, and MR elastography, we tend to send a patient to big hospital, because not all the single imaging center down the road, they might not carry an MR elastography machine. And we have long waiting lists for MRE. So I think those we need to take it in consideration if you want to find out the patient, if they have any liver stiffness, or if you don't need to order any contrast, you might consider just FibroScan instead of MR elastography. So this slide, I like it a lot. Basically, it's kind of summarize what I just told you. It tells you the 4 key NIT that we use on daily basis. What is the component, what is the cutoff, and what is the limitation and strength. So the first 154, they call it indirect serum fibrosis biomarker. They did tell you 4 different components. The cutoff is less than 1.3. You kind of rule that out if the patient that they have high level of fibrosis. And if the patient has higher than 2.67, you might consider probably the patient might have early cirrhosis or high level of fibrosis, but 30% of the patient fall inside the indeterminate range. So you might need a next level of NIT because we need to take the consideration of patient's age, because FIB4 including the patient's age to calculate the number. And the next one is direct serum fibrosis biomarker, is ELF test. I remember that test actually has at least did 3 different range, less than 7.7 or greater than 9.8 or greater than 11.3. Good thing is this test has high level of negative predictive value. So if the patient's range is really less than 7.7, you kind of rule out the patient has advanced fibrosis. So the next one is imaging fibrosis biomarker, is VCTE and MRE. They both use same unit kilopascal, but the cutoff is completely different. It's a little confusing. The VCTE use 8 kilopascal, you rule out the advanced fibrosis, versus MRE is less than 2.5. And for VCTE, if anything about 8 kilopascal, you have to refer to see hepatologist, because you suspect the patient might have fibrosis. Or if it is greater than 12, you probably think the patient might have early cirrhosis. The patient might require liver cancer screening down the road. And MRE, I did mention about it is very accurate, and it has at least 4 different advantages, can give you a lot of information: iron overload and fat and fibrosis and liver lesions. You can tell what kind of liver lesion the patient has, but unfortunately it's expensive, and also insurance might not approve. So let's come back to our case. And Mr. Albert, we did diagnose he has MASLD. So what should we do for this patient after I explained a lot of NITs? And then very important that I think this is my last slide, and I really want to focus on this slide and let people know when we see MASLD patient, what should we do? This is a MASLD care pathway. So I think it's very important when we see the patient, and we need to identify the patient at risk for MASLD. So patient came in, if they have liver test elevation, or if they have any imaging of liver or abdomen and show a hepatic steatosis, we want to find out if the patient has any metabolic risk factors, such as type 2 diabetes or any cardiometabolic risk factor, hyperlipidemia and hyperpressure, which Mr. Albert has all those like metabolic diagnosis. Oh, recommend check alcohol use. Yes, Dr. Saab, I'm going to talk about it in step 2, actually. You are jumped to the point ahead of me, actually. So step 1 is identify risk factor, right? So after the metabolic symptom, and then step 2 is very, very important. Ask the patient the history if they drink alcohol. So if the patient actually come in, it show hepatic steatosis on ultrasound, but is it truly just MASLD or MAT-ALD? We always ask history. We always ask if the patient drink alcohol or not. So step 2 is we need to ask the patient how much alcohol they drink, because we tend to see patient minimize alcohol consumption. And they, as a woman, we should not drink more than 7 glasses of alcohol per week. As a man, maximum, I would say 14 glasses of alcohol per week. And we also need to check PAF test. Is really, really important, because PAF test, it can give an idea for a month alcohol consumption. And basically the patient cannot lie about drinking alcohol. And if the patient never have any baseline of liver function test or CBC, I definitely will check that, because by checking the platelet count, we kind of know if the patient has early cirrhosis. If the patient's platelet count is less than 130, we think the patient might have early cirrhosis. And if the patient has liver test significantly elevated, and then we probably need to dig into more to see if there's any DILI or maybe any kind of like autoimmune hepatitis instead of just MASLD. So after we go step 2, step 3 is we need to do risk stratification. we we need to order NIT to determine if the patient has any fibrosis or at any risk to develop advanced fibrosis down the road. So for Mr. Albert, we we actually put in FIB-4. We calculate the score is 2.22. So he fall into that 30% in determined risk. So the next level is we need to order FibroScan. Here, FibroScan, we particularly look into liver stiffness measurement is kilopascal. So kilopascal is way more important than the CAP score because kilopascal is tell you how much liver stiffness the patient has, is the fibrosis. So fortunately, Mr. Albert's FibroScan, the kilopascal is 6.7. And here they did mention about low risk fall into the blue category. I will actually suggest repeat the NIT in 1 year instead of 2 to 3 years. Here they did mention about 2 to 3 years because I do see a patient like last week and I review her FibroScan. 2 years ago, her FibroScan actually show F0 to 1, and then last month show F3. So if we order 2 to 3 years, we actually miss the golden point that we can actually treat MASH, because now we have a great medication to treat MASH if the patient that they have F2 to 3 fibrosis. So I personally will repeat the NIT on yearly basis. But I think you also need to consider the risk factor. And if for Mr. Albert, he has all the metabolic symptom and also he has type 2 diabetes and overweight, definitely I will order the NIT on yearly basis. And if the liver stiffness measurement is greater than 8, that you need to refer the patient to see a hepatologist. It's very, very important because we work with endocrinologists and also we work with dietitian. We can give the patient a wide range of management to monitor the lifestyle modification and also weight loss and manage the metabolic disease. And also very, very important, if the patient that they have cardiovascular risk factor or any family history of cardiovascular disease, we need to refer the patient to see cardiologists because number one leading cause for MASH is cardiovascular disease. It's not decompensated cirrhosis or liver failure. So it's very important. If the liver stiffness measurement is greater than 12, I think the patient might have early cirrhosis. Then we need to screen for liver cancer every 6 months. It's very important because patients are really truly at risk to develop liver cancer down the road, and particularly if the patient that they are old age. So I'm going to stop right here, but I think this is my last slide.